Organizers for inviting me to talk about endoscopic weight loss procedures as alternatives to surgical options. These are my disclosures. So I don't really need to talk about this too much. We know that there is a lot of obesity, not only in the United States, but around the world. And it's becoming worse. This is a little bit old data from 2015, and I'm just comparing Egypt and United States, and we can see both countries have a significant problem with obesity. And, from basically 27 to 40, 43, 41% rate of obesity, depending on the gender. And so this definitely needs to be addressed. What I didn't know actually was that there's a larger burden of disease in Egypt, in Eastern Europe, in Northern Asia, where for the same elevation in BMI, there's a much higher attributable mortality rate. So it's obviously a huge problem and it needs to be addressed. Patients do need to lose weight. And so the question is, how do we get them to lose weight? There's always diet and exercise. It's the most important thing. It's what everybody needs to do. Doesn't matter if they get a procedure, doesn't matter if they get anything. I tell them everybody has to have a proper diet and needs to get active, needs to use those calories, exercise. But that just doesn't work for everybody. And or it works well, but then they have weight recidivism. They gain the weight back. They're just not able to make some of those changes, or they're just not able to be even active. Too many medical problems. And so we have tools to help them lose weight. And these are the traditional tools, of course, medications. They're simple. You can take medications. It'll curb your appetite. It'll and you start losing weight. But you can regain weight after stopping the medications, or there's surgery, which are fantastic. They work really well, but the problem is that you start getting increased risk with these procedures, risk of perforation, risk of leaks, risk of bleeding, and delayed risk stenoses, et cetera. And so there is this little area in the middle where, there are procedures that aren't as risky, and that's where endoscopic options come into play. Now, I have 10 minutes for this talk, so I don't have a lot of time to talk, but I will go through everything as quick as I can and try to touch into it. I won't be able to get into a lot of details. These are, this is not a comprehensive list, but these are the main areas of primary endoscopic therapies and ways that people can lose weight, ways that an endoscopist or a gastroenterologist can help patients lose weight. I want to first talk about number 3 and 4. And the reason I want to talk about those is that because they're actually not available anymore, but you might see these and you might see data on them. So I just wanted to actually just make sure you're aware. So this Transpyloric Shuttle, this is a dual bulb system device that sits in your pylorus and basically just intermittently blocks the pylorus. That's the idea, and helps people lose weight. It has at least FDA approval, and I think the company is moving forward with some of the approval, but I just haven't heard from them in a while, and nothing is currently available. So that's not, I'm gonna put as not available at this time. The other one was Aspiration Therapy. This was where a feeding tube was actually placed, a gastrostomy tube was placed into the stomach, but instead of feeding, it would work the other way around. About 20 to 30 minutes after people ate, they would drain whatever was left in the stomach. For the patients who bought the idea, who understood it, who used it, it worked really well. It's very low risk. The problem is that many patients just weren't attuned to the idea of going to the bathroom and dumping whatever is left in their stomach into the toilet. So that company has actually closed down very recently. They no longer are offering any product. The small bowel therapies, number 5, these are the duodenal jejunal bypass liner was available for a little bit, it had a CE approval in Europe, but it isn't currently available, and they are trying to get back. And the endoscopic jejunal ileal anastomosis, that's a magnet system that is able to create an anastomosis between the jejunum and the ileum, all endoscopically. It's not available yet, but it is being worked on. And so that leaves us back to number 1 and 2, the intergastric balloon and sleeve gastroplasty, which I'll focus on to some degree today. Intergastric balloons. So these are balloons that are placed into the stomach. It's a space-occupying device. There's just not as much space for patients to eat food, and so they don't eat as much. In addition, because there's this big sort of balloon in the stomach, the stomach isn't able to empty as well. And so it delays gastric emptying, and the patients, whatever they eat, they don't eat as much, and it stays in their stomach longer. This was an old Garen Edwards balloon that was the original balloon that was developed in the 80s. The problem with it, of course, is that it was a cylindrical shape. It was sharp. It caused many problems, and so it didn't last very long on the market. And actually, the United States stopped having balloons for a very long time because of that. All right, so what's good about these intragastric balloons? Well, patients get about a 10 to 15% expected weight loss. There are some adverse events, though, as would be expected for anything. Patients do have a lot of nausea and vomiting. And that's the main complaint that they'll have. They feel this in their stomach. They feel the nausea, the vomiting, and to the point where a lot of time it's about 5% of patients really have to get the balloon taken out. Patients do have some abdominal pain, usually goes away in about 2-3 days. And then rarely over time, they can develop ulcers or gastritis as this balloon kind of rubs up against the stomach. And then patients are given a PPI for that reason. There are some rare serious events, including migration. So this balloon can deflate and then migrate into the small intestine and then get stuck there, has to be taken out endoscopically or via surgery. And it also can cause perforation in the stomach. It's been reported in the literature, but they're very rare. All right, so what is currently available? The main ones that are currently available are the Orbera. So this is the sort of the original one that was developed a while ago, and it was approved in 1996 initially, clinically available. The Spats, the unique thing about this is the Spats balloon is that actually is an adjustable balloon. So once it's placed, it can actually be adjusted. And the Ellipse, which actually is a non-endoscopic balloon. It's swallowed and then filled, and then it degrades over time. So I want to quickly talk about each one of these. The Orbera, as I mentioned, it's endoscopically placed. And once it's endoscopically placed, you make sure it's in the right location. You leave it there for about 6 months in the United States or 12 months in certain other countries. The balloon is filled with about 400 to 700 ml of saline with methylene blue. And the methylene blue is in case it deflates, patients see green urine, they come right back to you. And the Orbera, there's the most data on it, the most safety data on it, but patients have about a 10 to 13% total body weight loss. And I tell my patients about 10 to 15% total body weight loss. The next one is the Spats. As I mentioned, it's adjustable. So once it's placed, it is placed endoscopically. There's a catheter that goes with the endoscope that's attached to it, and then it's placed. It's filled with about the same amount of fluid, and then you watch the patient. If they're really nauseous, they want to get something out, you can just go and do an endoscopy and take some fluid out, and they feel a little bit better, and they maybe do fine. Or 2 months from then, they'll say, you know what, I really am not losing enough weight. You go back in and you just fill up more with more fluid and see how they do. And the data is very good. It's about 15 to 16% total body weight loss, but the cost with these repeated endoscopies can get a little bit high. But it's a pretty good option, and it's available now. And the Ellipse, this is not available in the United States, but it is a unique concept. It is swallowed, so under fluoroscopy, and it's filled with 550 ml of aqueous solution with another solution in there. The seal, so the seal and this balloon degrades in about 4 months. And so once it degrades, all the fluid comes out, and the balloon deflates, and it is designed to then pass through the colon spontaneously. Over 4 months, patients lose about 11 to 14% of their total body weight, which is pretty good. And then, of course, you can just put another balloon. You can swallow another balloon after that and try to lose more weight. These are a couple of other balloons that you may have heard of, or you might have seen. The Obalon, this was also a swallowed balloon. These were 3 separate balloons that were put in every 2 weeks and then left in there for 6 months, and patients did fine, but the company did have to close down. And then the Reshape Duo, it's a sort of a dual balloon. So in case one pops, you get blue, you get green in your urine from the methylene blue, and you know that the other part needs to be taken out. This one got bought actually by the company that that makes Orbera, and so they are no longer in the market. They stopped marketing that, and so these are not available. All right, and those are pretty much balloons. That's an overview of balloons. The other area that's very exciting is sleeve gastroplasty. So this is a procedure that is, it's a restrictive procedure where the stomach volume is reduced using the Apollo overstitch device. There is another suturing device. It's not really a suture ring, it's more of a plication device, the IOP, available by USGI. Not as much, it's not as universally available, so I'm not going to talk about it too much, but it is some data that the Thompson group does publish on. And the idea here is that really emulates the anatomy of a sleeve gastrectomy using endoscopic suturing. So I don't have time to show an entire procedure, but this is a
Dr. Abidi?
Yes.
In the sake of the time, we just need to wrap up, please.
Okay. And so this is a stomach where the gastroplasty has been, and you can see the gastroplasty, and it's a much narrower stomach afterwards. Patients lose about 15 to 20%, so it's already become surgical level weight loss at 24 months, and my patients really do well. There are, of course, adverse events. A lot of abdominal pain, bleeding, perigastric fluid collections have been reported, but are still very rare. Okay, I'm not going to talk about revisions, but this is something that's been available for a while. Patients after a gastric bypass can be revised to make smaller. They can lose weight. It can help with dumping syndrome. And then there's a sleeve and sleeve revision, which Girapino et al. Have recently published about, and they're actually speaking at this conference as well, and where a sleeve can be made narrower and shorter. All right, in conclusion, bariatric therapies are becoming important tools in the treatment of obesity and related conditions. With the appropriate lifestyle therapy, patients can see total body weight loss of 6 to 20%, and there are more devices that are coming on. Some of them are going to be geared towards diabetes and obese patients. Thank you.
Thanks, Dr. Abidi. It's very excellent.